Hello and welcome, future nurses. You are tuned in to NCLEX, your ultimate destination for mastering nursing concepts with clarity and confidence. Here, we post 2 to 3 advanced NCLEX videos every single day, packed with high-yield content, real-world clinical reasoning, and StanCoast pearls that turn every lesson into lasting knowledge. Today's critical care focus is on nursing care of clients with chest injuries. This session covers one of the most urgent topics in emergency and trauma nursing, where quick thinking, accurate assessment, and precise interventions save lives. You will learn how to recognize the signs of life-threatening complications like pneumothorax, hemothorax, and flail chest, how to perform rapid assessments using the ABC approach, and how to manage chest tubes, oxygen therapy, and pain control. We will also explore priority nursing actions, post-injury monitoring, and client education to prevent complications and promote recovery. So stay with us till the end, because this session is not just about passing the NCLEX, it is about thinking like a trauma nurse under pressure. And always remember, at StanCoast NCLEX, we do not just teach content, we build confidence, competence, and compassion. Let us begin today's high-impact session on chest injuries.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now move into this first insightful NCLEX-style scenario that highlights the critical importance of respiratory care following thoracic trauma. A 17-year-old high school football player arrives at the emergency department after a hard collision during practice. The nurse observes shallow breathing, localized tenderness, and bruising over the left lower ribs. A chest X-ray confirms fractures of the 8th and 9th ribs without pneumothorax. Once the client's condition is stabilized and pain medication is given, the nurse prepares to provide essential discharge education. The question is, which instruction should the nurse emphasize most to prevent respiratory complications after discharge? Here are the options to consider. Option A, breathe deeply and cough several times every hour while awake. Option B, take shallow breaths to minimize pain. Option C, breathe rapidly to promote ventilation. And option D, breathe into a paper bag every hour to relieve discomfort. The correct answer is option A, breathe deeply and cough several times every hour while awake. Now, let us explore the rationale in depth. When ribs are fractured, clients often experience pain-induced hypoventilation, meaning they instinctively take shallow breaths to avoid discomfort. However, this protective response can have dangerous consequences. Shallow breathing decreases alveolar ventilation, allowing secretions to accumulate, mucus plugs to form, and alveoli to collapse, a condition known as atelectasis. Atelectasis severely impairs oxygen exchange and can quickly progress to pneumonia, especially in young athletes whose oxygen needs are higher due to their active metabolism. Encouraging the client to breathe deeply and cough every hour promotes full lung expansion, mobilizes mucus, and maintains adequate ventilation. The nurse should also demonstrate splinting techniques, such as holding a pillow against the injured side while coughing or taking deep breaths, to minimize pain and enhance compliance. Additionally, incentive spirometry can be introduced to provide visual feedback and motivate deep inhalation, reducing the risk of post-traumatic pulmonary complications. During discharge teaching, nurses must also stress maintaining adequate pain control to support effective breathing, avoiding restrictive chest wraps or tight bandages, and promptly reporting warning signs like shortness of breath or increased pain, which could indicate a pneumothorax or infection. Transitioning now to why the other options are incorrect. Option B, take shallow breaths to minimize pain. Incorrect. While shallow breathing might temporarily ease pain, it actually increases the likelihood of atelectasis and hypoxia. The primary nursing goal is to maintain oxygenation and prevent respiratory compromise, even if that means managing pain proactively. Option C, breathe rapidly to promote ventilation, Incorrect. Rapid, shallow breathing only increases dead space ventilation, air movement that does not participate in gas exchange, and fatigues respiratory muscles without improving oxygen delivery. Deep, slow, and controlled breathing is required to expand alveoli fully. Option D, breathe into a paper bag every hour to relieve discomfort. Incorrect. This technique is reserved for hyperventilation due to anxiety or panic attacks. In the context of rib fractures, it can cause dangerous carbon dioxide retention and exacerbate hypoxia, making it unsafe and ineffective. Before we wrap up, let us reflect on an important insight. Stand coast. Clinical insight. When ribs fracture, breathing becomes an act of courage. The nurse's role is to turn painful, hesitant breaths into purposeful expansion, protecting each alveolus from silent collapse. And finally, here is your Stand Coast high-yield NCLEX pearl. Teach clients to splint the chest with a pillow during deep breathing and coughing. Encourage the use of incentive spirometry at least 10 times every hour while awake. Avoid any chest binding or wrapping that restricts lung expansion. Always prioritize pain control before respiratory exercises to ensure the client can breathe deeply and effectively. Let us now step into an intense trauma scenario that truly challenges your critical thinking and clinical judgment in emergency nursing. Picture this. While on the way to work one morning, a registered nurse witnesses a high-speed motorcycle accident and immediately stops to assist the injured victim. Upon rapid assessment, the nurse observes severe respiratory distress, asymmetric chest wall movement, and palpable crepitus over the left lateral thoracic region. The question now arises, which finding most strongly suggests the presence of flail chest? Here are the options to carefully evaluate. Option 1, a sucking sound of air near the chest wound. Option 2, tracheal deviation from the midline. Option 3, a portion of the chest wall moves inward during inspiration and outward during expiration. Option 4, severe chest pain that worsens during expiration. The correct answer is Option 3. A portion of the chest wall moves inward during inspiration and outward during expiration. Moving forward into the expanded rationale, let us understand this condition in greater depth. Flail chest is a serious, life-threatening consequence of blunt thoracic trauma, where 2 or more adjacent ribs are fractured in at least 2 places each, creating a free-floating segment of the chest wall. This unstable segment becomes mechanically disconnected from the rest of the thorax, producing paradoxical chest movement, which is the hallmark sign of flail chest. During inspiration, negative intrathoracic pressure pulls the flail segment inward, the opposite direction of the rest of the chest wall. During expiration, when intrathoracic pressure becomes positive, the segment bulges outward. This abnormal motion significantly compromises ventilation and oxygenation, leading to hypoxemia, respiratory distress, and frequently an underlying pulmonary contusion beneath the injured ribs. In addition, because of the unstable chest wall, tidal volume drops, and the client often exhibits shallow breathing, cyanosis, tachypnea, and extreme pain. This paradoxical movement results in inefficient gas exchange and an increased risk of atelectasis and hypoventilation, making early identification absolutely essential. The nurse's immediate priorities should include maintaining a patent airway, supporting ventilation with oxygen or positive pressure if necessary, stabilizing the flail segment using manual pressure or bulky dressing, and preventing shock until emergency medical personnel arrive. Transitioning now to the incorrect options, Option 1, a sucking sound of air near the chest wound, describes an open pneumothorax, not flail chest. This condition occurs when air enters the pleural cavity through an open chest wound during inspiration, leading to lung collapse, but without rib fractures or paradoxical motion. Option 2, tracheal deviation from the midline, indicates a tension pneumothorax, caused by trapped air shifting the mediastinum and compressing the unaffected lung. Although both tension pneumothorax and flail chest can occur following trauma, tracheal deviation is not a hallmark of flail chest. Finally, Option 4, severe chest pain that worsens during expiration, is nonspecific. While pain is common in thoracic injuries, it is not diagnostic of flail chest. In fact, pain typically intensifies during inspiration due to chest expansion, but by itself does not signify mechanical instability. Transitioning to a deeper clinical reflection, let us now explore the Stand Coast clinical insight. In flail chest, the chest wall no longer works as one. It moves against itself. Each paradoxical rise and fall robs the lungs of oxygen, demanding immediate stabilization and respiratory support to prevent the silent suffocation of internal collapse. Now, moving toward the Stand-Coast High-Yield NCLEX Pearl, paradoxical chest movement is the hallmark feature of Flail chest. Provide positive pressure ventilation or intubation in cases of severe respiratory distress. Prioritize aggressive pain control to facilitate effective ventilation and prevent fatigue. Monitor closely for complications such as pneumothorax, hemothorax, pulmonary contusion, and shock. Always remember, rapid emergency stabilization using manual pressure, bulky dressings, and high-flow oxygen can make the difference between life and death in Flail chest management. Let us now dive into this next high-impact trauma scenario that tests both your clinical reasoning and understanding of chest tube management. Imagine this. After a severe motor vehicle collision, a client is rushed into the emergency department showing profound respiratory distress and symptoms of hypovolemic shock. Upon imaging, a left-sided hemothorax is revealed, containing approximately 1,200 milliliters of blood in the pleural cavity. To restore lung expansion, 2 chest tubes are inserted, one placed in the second intercostal space at the midclavicular line, and another in the fifth intercostal space at the midaxillary line. The nurse must now closely monitor which tube produces the appropriate type of drainage. Moving on to the options for this question. Option 1 suggests drainage from the client's nose. Option 2 suggests drainage from the client's mouth. Option 3 points to the upper chest tube. And Option 4 refers to the lower chest tube. The correct answer is Option 4, from the lower chest tube. Now, let us explore the expanded advanced rationale to understand why this answer is accurate. A hemothorax occurs when blood accumulates within the pleural cavity, typically following blunt or penetrating trauma that damages pulmonary or chest wall vessels. The buildup of blood compresses the lung, preventing full expansion and disrupts normal gas exchange, resulting in respiratory distress and hypoxia. Chest tube insertion in this context is crucial, as it allows evacuation of air and fluid to restore negative intrapleural pressure and facilitate lung re-expansion. In this dual-tube setup, each tube serves a distinct function influenced by anatomy and gravity. The upper chest tube, placed higher in the thorax, usually in the second intercostal space, removes air because air naturally rises. Conversely, the lower chest tube, positioned in the fifth or sixth intercostal space, drains blood and other fluids since these heavier components settle in the dependent portions of the pleural cavity. Therefore, in a pure hemothorax, the nurse should expect to observe bloody drainage specifically from the lower chest tube, confirming proper function of the drainage system. By contrast, drainage from the nose or mouth indicates upper airway or pulmonary bleeding, not pleural drainage. Similarly, the upper chest tube would mainly evacuate air, suggesting pneumothorax or hemopneumothorax rather than hemothorax alone. Understanding these distinctions allows the nurse to identify early complications, such as tube blockage, persistent bleeding, or inadequate lung re-expansion. Finally, consistent monitoring of drainage characteristics is essential. If drainage exceeds 200 milliliters per hour for 3 consecutive hours, it signals active intrathoracic hemorrhage, requiring immediate physician notification. Now, before we conclude, let us reinforce this concept with an insightful Stand-Coast clinical insight. When a hemothorax floods the pleural space, the lung cannot rise until gravity helps drain the weight of blood. The lower chest tube becomes the lifeline, allowing the lung to reinflate and the breath to return. Moving forward to the Stand-Coast High-Yield NCLEX Pearl. Upper chest tube removes air. Lower chest tube drains blood and fluid. Sudden cessation of drainage may indicate clot obstruction. Rapid increase in drainage suggests ongoing bleeding. Always assess bilateral breath sounds and chest expansion after insertion. Hold on.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now smoothly transition into another critical trauma-based scenario that demands strong assessment and reasoning skills. A trauma client has just been admitted with a left-sided hemothorax following a severe motor vehicle collision. To facilitate lung re-expansion and drainage, 2 chest tubes are inserted and connected to a commercial 3-chamber water seal drainage system. As the nurse evaluates this setup, attention is focused on the water seal chamber, and the question is, which observation best confirms that the system is functioning properly? Here are the options to consider. Option A. The fluid rises and falls with the client's respirations. Option B. The fluid level is lower than when first filled. Option C. The fluid bubbles continuously during inspiration and expiration. Option D. The fluid appears frothy and white. The correct answer is Option A. The fluid rises and falls with the client's respirations. Now, transitioning into a deeper understanding of why this answer is correct, when a chest drainage system functions properly, the nurse should observe tidling, which is the rhythmic rise and fall of water within the water seal chamber that synchronizes with the client's respiratory cycle. During inspiration, intrathoracic pressure becomes more negative, causing the water level to rise, and during expiration, it falls as pressure equalizes. This fluctuation proves that the system is patent, that air can escape from the pleural cavity, and that no obstruction or disconnection exists. It also confirms that the water seal chamber is maintaining its one-way valve mechanism, allowing air and fluid to exit but preventing their return, thereby promoting lung re-expansion after injury or surgery. However, it is equally important to recognize when tidling stops suddenly, as this could indicate one of 2 things. Either the lung has fully re-expanded, eliminating pressure changes, or there is an obstruction due to kinking, clotting, or dependent loops in the tubing. Moving on to the incorrect findings for a more comprehensive review. Option B, which states that the fluid level is lower than when first filled, is incorrect because this points to evaporation or leakage. The chamber should always maintain a constant level of 2 centimeters of sterile water, which ensures the one-way seal remains intact. A low water level can allow air to be sucked back into the pleural cavity, risking lung collapse. Next, option C, which says the fluid bubbles continuously during inspiration and expiration, is also incorrect, because this signifies an air leak either from the client, such as in a persistent pneumothorax, or within the drainage tubing. Bubbling should only be intermittent, for example, when the client coughs or exhales soon after tube insertion. Continuous bubbling needs immediate assessment using a clamp test to pinpoint the leak. Finally, option D, which describes the fluid as frothy and white, is incorrect because this appearance signals contamination or infection. The water seal chamber should remain clear at all times. Frothiness often results from agitation or mishandling of the system and can interfere with accurate assessment of drainage function. Transitioning now to a Stan Coast clinical insight. Think of the water seal chamber as the lung's external valve. When it gently breathes in rhythm with the client, the system is alive and functional. Silence or constant bubbling tells a story. The lung is either healed or the system is leaking. The vigilant nurse interprets that story before danger sets in. Moving forward to the Stan Coast high-yield NCLEX Pearl. Gentle rise and fall of water with respirations equals system patent and working. Continuous bubbling equals air leak. Investigate immediately. No tidling equals possible lung re-expansion or obstruction. Always maintain 2 centimeters water level to preserve the one-way seal. Never clamp chest tubes unless specifically ordered for troubleshooting or replacement. Let us now transition into a critical trauma scenario that truly tests your clinical assessment skills. Imagine a trauma client who has just had a chest tube inserted and connected to a 3-chamber water seal drainage system. Shortly afterward, the nurse notices swelling and a distinct crackling sensation under the skin near the insertion site. Upon palpation, it feels like popping Rice Krispies. Now, the question arises. Which assessment finding most accurately indicates that air is leaking into the subcutaneous tissue around the chest tube site? Here are the options to consider. Option A, the tissue appears pale or colorless. Option B, a hissing sound similar to a leaking tire can be heard. Option C, the skin crackles when palpated. Option D, air can be felt escaping from the insertion site. After carefully evaluating all possibilities, the correct answer is Option C, the skin crackles when palpated. Moving into the rationale, This finding describes a condition known as subcutaneous emphysema, also referred to as crepitus. It occurs when air escapes from the pleural space and becomes trapped within the soft tissue around the chest tube insertion site. The nurse identifies this by gently palpating the area and feeling that distinctive crackling or popping sensation, much like the sound of crisp rice cereal in milk. These sensations occur because small air bubbles move through the tissue layers, creating vibrations under the skin. While it often stays localized around the chest tube site, it may spread to the neck, chest, or even the face if the air leak worsens. Furthermore, subcutaneous emphysema is not always an immediate emergency, but it does require close monitoring. If crepitus extends upward toward the neck or face, it may indicate an enlarging air leak or a malfunctioning chest drainage system. In severe cases, trapped air can compress the trachea and threaten airway patency. Therefore, the nurse must promptly assess the entire chest tube setup, ensure the dressing is secure and airtight, and notify the healthcare provider if swelling progresses, or if the client develops respiratory distress, voice changes, or facial swelling. Transitioning now to the incorrect options. Option A, stating that the tissue appears pale or colorless, may occur secondarily from localized swelling or impaired circulation, but it does not confirm subcutaneous emphysema. Pale tissue is a nonspecific sign that could be linked to edema or reduced perfusion, not an air leak. Next, option B, which describes a hissing sound like a leaking tire, would indicate that air is escaping externally into the environment, a feature of a loose connection or open wound, not subcutaneous air trapping. In true crepitus, the air is dispersed within the tissues and remains silent. Finally, option D, which mentions feeling air escaping from the insertion site, suggests that the drainage system is no longer sealed or that the tube has been dislodged. In contrast, subcutaneous emphysema involves air moving internally beneath the skin, not visibly escaping. And now, before we conclude, here is your Stan Coast clinical insight. When the skin whispers with crackles, it speaks of air that has lost its path. Crepitus is the nurse's early warning, an invisible leak that can only be heard through touch. The vigilant nurse uses both ears and hands to detect what the lungs cannot say. Transitioning finally to your Stan Coast high-yield NCLEX pearl. Crackling under the skin signifies subcutaneous emphysema, which means air has leaked into the soft tissue. Rapid spread to the face or neck is a red flag sign of potential airway compromise. Notify the provider immediately. Always inspect the tubing and all connections for possible leaks and reinforce the chest dressing if needed. Remember, gentle rise and fall of the water seal indicates normal titling, while continuous bubbling signals an ongoing air leak that requires investigation. Let us now transition into an advanced trauma scenario that highlights safe transport management for clients with chest tubes. Imagine a trauma client with a left-sided pneumothorax, whose chest tube is connected to a 3-chamber water seal drainage system operating on wall suction. The physician orders a transfer to the radiology department for a portable chest X-ray, and the nurse must ensure the system remains intact during this process. The critical question here is, which nursing action is most appropriate before and during the transport? Moving forward to the options, let us carefully evaluate each choice. Option A, clamp the chest tubes before leaving the room. Option B, keep the drainage system below the level of the chest insertion sites. Option C, attach the chest tubes to a portable suction device. Option D, provide mechanical ventilation support during the transport. After assessing the scenario and options, the correct answer is option B, keep the drainage system below the level of the chest insertion sites. Now, let us break down the rationale in detail. Keeping the drainage system below the level of the chest insertion sites ensures that gravity continues to promote the downward flow of air and fluid from the pleural space, preventing any backflow and reducing the risk of a recurrent pneumothorax. The chest drainage setup functions on a simple yet vital principle, maintaining a one-way flow through the water seal chamber, which allows air to escape from the pleural cavity without re-entry. If the system is raised above chest level or accidentally tipped, drainage may reflux into the pleural cavity, possibly causing lung collapse or tension pneumothorax. Before transport, the suction tubing is disconnected temporarily, while the water seal remains intact. The nurse must verify that all tubing connections are secure, the collection device is upright, and the water seal is functioning properly. During transfer, continuous observation for respiratory distress, bubbling in the water seal, and tubing integrity is essential. Thus, keeping the system below chest level maintains both gravity drainage and patient safety throughout the movement. Transitioning to the incorrect options, let us explore why the other choices are inappropriate. Starting with option A, clamping the chest tubes before leaving the room is a dangerous practice unless specifically indicated for brief system changes or leak checks. Clamping traps air inside the pleural cavity, leading to rising intrathoracic pressure that can precipitate a tension pneumothorax, a medical emergency manifested by tracheal deviation, hypotension, and absent breath sounds on the affected side. Next, examining option C, attaching the chest tubes to a portable suction device is not required for short transports or radiologic evaluations. The water seal system alone maintains safe intrapleural pressures for the brief duration without wall suction. Improper or excessive suction may compromise the seal and cause unnecessary negative pressure trauma to lung tissue. Once the client returns to the unit, wall suction can safely be reconnected. Finally, evaluating option D, providing mechanical ventilation support during transport, is not indicated for stable clients with functioning chest tubes. Mechanical ventilation is reserved for those with respiratory failure or inadequate spontaneous breathing. Using it unnecessarily can disrupt normal intrathoracic pressure gradients, alter drainage mechanics, and even exacerbate air leaks. Transitioning now to the Stancoast clinical insight. Before any client with a chest tube leaves the unit, the nurse's central goal is to safeguard the one-way water seal system that keeps the lung inflated. Think of the chest tube as a lifeline, a bridge that allows trapped air and fluid to escape. Gravity keeps this bridge functioning properly, and vigilance ensures the lung remains expanded. A simple oversight, like lifting the drainage system above chest level, can undo hours of healing. Moving forward to the Stancoast high-yield NCLEX Pearl, always keep the water seal drainage system below chest level to maintain gravity-assisted drainage. Never clamp chest tubes during transport. Doing so can trigger a tension pneumothorax. If suction is ordered, disconnect wall suction temporarily, but maintain the water seal during movement. Observe the client closely for any signs of respiratory distress, bubbling, or compromised tubing. Early detection prevents serious complications. Let us smoothly transition into this next advanced level, NCLEX-style question, that challenges your precision and clinical judgment in managing a client with a chest tube. Imagine a nurse monitoring a client who has a left-sided chest tube connected to a closed 3-chamber water seal drainage system following surgery for a pneumothorax. During the shift assessment, the nurse must determine the exact amount of drainage produced over the last 8 hours. Now the question is, which method provides the most accurate measurement of chest tube drainage? Moving forward to the options, let us evaluate each carefully. Option A, empty the collection chamber and measure the total volume obtained. Option B, subtract the client's total fluid intake from the drainage output. Option C, instill sterile irrigation solution and measure the drainage return. Option D, subtract the previously marked drainage level from the current total volume on the calibrated collection chamber. The correct answer is option D, subtract the previously marked drainage level from the current total volume on the calibrated collection chamber. Now transitioning into the detailed rationale, accurate measurement of chest tube drainage is a vital nursing responsibility, because even slight variations in output or appearance can indicate serious complications such as hemorrhage, infection, or tube malfunction. In a closed chest drainage system, the collection chamber is calibrated to display the cumulative total since the system was connected. Therefore, to calculate the true amount drained during a specific shift or time interval, the nurse should subtract the previous marked level from the current total volume. This method ensures accuracy and continuity across caregivers. At every shift change, the nurse should use a permanent marker to record the level, along with the date and time, to provide clear trending data and prevent misinterpretation due to cumulative readings. Furthermore, it is crucial to assess not just the quantity, but also the color, clarity, and consistency of drainage. Initially, drainage may appear sanguineous after surgery, then gradually transition to serosanguineous, and finally serous as healing progresses. Any sudden increase in bright red drainage exceeding 100 milliliters per hour, or reappearance of frank blood after the first 24 hours, signals potential active bleeding and warrants immediate provider notification. Let us now clarify why other options are incorrect. Option A, emptying the chamber and measuring total volume, breaks the sterile integrity of the system and may result in loss of negative pressure, risking infection and compromised function. Option B, comparing fluid intake with drainage output, is unrelated to chest tube management and does not provide valid data. Option C, instilling sterile irrigation fluid to measure return, is contraindicated unless ordered explicitly for maintaining tube patency under sterile control, as it introduces infection risk and alters drainage accuracy. Transitioning to additional nursing implications, the system must always remain upright and positioned below chest level to maintain gravity-assisted drainage and prevent dangerous backflow into the pleural space. Continuous monitoring for air leaks, bubbling, and fluctuations is also critical to ensure effective re-expansion of the lung. Now, let us move into the Stan-Coast clinical insight. As every milliliter in the chamber narrates a story of the lung's recovery, the vigilant nurse interprets each shift's markings as a dialogue between healing and complication. Accurate documentation transforms observation into life-saving precision. Next, transitioning into the STANCOAST high-yield NCLEX Pearl. Always measure chest tube drainage by subtracting the previous marking from the current total. Never empty the chamber, as it disrupts sterility. Record the drainage level with date and time at each shift change for consistent trending. Normal postoperative drainage is initially bloody, up to 100 to 200 milliliters in the first few hours, and then becomes serosanguineous before tapering. Immediately report drainage that becomes bright red after 24 hours or exceeds 100 milliliters per hour. Maintain the drainage system upright and below chest level at all times to preserve gravity flow and prevent backflow complications.